Good afternoon, everyone. I'd like to introduce you to Dr. Creighton. Dr. Creighton completed her medical education and residency program in pediatrics at the University of Illinois College of Medicine. She then completed a fellowship at the Medical College of Wisconsin in pediatric cardiology. She was awarded the Patient Advocate Award from Children's Hospital of Wisconsin in 2008 and 2011. Dr. Creighton is a board certified in pediatrics general and practices at the Children's Hospital of Wisconsin, Fox Valley location. Here we go to Dr. Creighton.
Hello, everybody. Like I said, I'm Sarah Creighton. I did a lot of my training in Illinois and moved up to Wisconsin, and then was offered the opportunity to keep moving up north and took it, which I love, and my husband doesn't really love as much, but he can deal. He grew up in the Chicago area too. So today I'm going to be talking about diagnosing congenital heart disease in the fetus and in the newborn. It kind of spans where my specialties lie. I'm a fetal and pediatric cardiologist. If you guys are familiar with any of the cardiologists in Children's in Milwaukee, my partner is Matt Philo, and I worked with Jeanette Strasburger, who is now in Milwaukee full-time doing research, so I'm kind of the lowly fetal and pediatric cardiology replacement from that standpoint. So I have nothing to disclose, no financial relationships or conflicts of interest, other than to say that I'm a Bears fan, so I'm sorry. It's what you get when you grow up in the Chicago area. So the learning objectives for today, there's kind of 4 basic things I wanted to talk about. First, I wanted to review fetal circulation and changes in circulation during the newborn period and kind of how that affects congenital heart disease. Then discuss really the general definition of critical congenital heart disease and what that actually means when we talk about that. Moving on then, how critical congenital heart disease is diagnosed in both the fetus and after delivery in the newborn, and then review the literature on how early diagnosis impacts outcomes in these patients with critical congenital heart disease. So, just in general, we talk about congenital heart disease as being relatively common in terms of congenital malformations in pediatric patients. The incidence overall is about 1%, probably 8 per 1,000 when we've done long-term studies. And when you look at the patients that have what we call critical congenital heart disease, that's about 25% of those patients, so somewhere between 1 to 2 in 1,000. We find that there's decreased mortality in our infants with critical congenital heart disease when they're delivered near a tertiary medical center, and that's from a Texas birth registry study that shows knowing that patients have critical congenital heart disease and delivery planning can help, and we'll help with outcomes, morbidity, and mortality. We'll talk about that a little bit later. So, fetal circulation. This takes you way back. But something I think about almost every day. So in the fetus, before birth, blood circulates obviously a little bit differently than it does after birth, mostly due to the lack of oxygenation by the lungs, and rather that oxygen travels for babies in the fetus through the placenta. And so oxygenated blood originates in the placenta and enters the circulation through the umbilical vein. The blood then moves through the ductus venosus. It gets directed to the heart through the IVC, and it goes through that ductus venosus specifically to avoid the liver from extracting oxygen and kind of taking it away from where it's actually directed to go. So it moves into the IVC, and then actually that IVC flow is preferentially directed across the eustachian valve, and that's really the only purpose of the eustachian valve. Through the foramen ovale and into the left atrium, so it bypasses going through the lungs. The blood then moves through the left heart and is pumped to the head and neck vessels preferentially, and so the most oxygenated blood that the fetus gets directed to the upper body. And if you think about it in a newborn, it makes sense. Their heads are kind of giant compared to the rest of their bodies, and that evens out as we get older, as well as their upper body. And it seems like their lower body is just a little bit smaller relative to the rest of their body size. On the other side, the deoxygenated blood from the head and upper body then moves to the heart through the SVC. Instead of being directed across the foramen valley, this blood's then directed across the tricuspid valve and pumped out through the pulmonary valve towards the lungs. But most of that blood then gets directed across the ductus arteriosus to the descending aorta, although a small amount goes out to the lungs. So just, we think flow equals grow in the fetus, so that the lung arteries develop. The blood then moves into the descending aorta, is brought back to the placenta by the two umbilical arteries, so that deoxygenated blood preferentially goes to the lower body and out back through the umbilical arteries to be oxygenated. Postnatal circulation obviously has many things that are different to get rid of that fetal circulation. So we think of the umbilical cord being cut here, and the baby starts to take its first breath and has oxygen coming into the lungs. So multiple physiologic changes occur because of these two big changes. First, the left atrial pressure rises, and the flat valve that covers the foramen ovale closes, so thus effectively closing the intraatrial shunt. The oxygen in the blood, because of the oxygenation and breaths taken by the lungs, encourages closures of the PDA. The placenta, because of the lack of placental flow, the ductus venosus closes as well. So then blood can then flow in series, where deoxygenated blood circulates through the right heart into the lungs to be oxygenated, and that oxygenated blood returns to the left heart, circulating through to be distributed through the rest of the body. So, now that the basic physiology lesson is over, we're just moving on to really how this impacts in our patients with congenital heart disease. So critical congenital heart disease. This is any form of congenital heart disease which requires an urgent treatment or some sort of intervention within the first 30 days of life that would prevent death or significant morbidity in that time frame. So these urgent treatments include initiation of prostaglandins, it could include an atrial septostomy, immediate surgical or ECMO intervention after delivery. But really, in that first month time period, something needs to occur for that baby to survive. So this examples of the different diagnoses that we consider critical congenital heart disease, which is, includes but not completely limiting to significant left ventricular outflow obstruction, so that's aortic stenosis, coarctation of the aorta, hypoplastic left heart syndrome, transposition of the great arteries, specifically without a ventricular septal defect, total anomalous pulmonary venous return, with or without obstruction, things like pulmonary atresia or significant pulmonary outflow obstruction as well. So, when we go back to that physiology, in critical congenital heart disease, fetal circulation really is really well tolerated by most babies with this type of heart disease. They're really unaffected due to the ability for blood flow to kind of bypass the normal outflows, to kind of use reverse flow across the ductus arteriosus and the foramen ovale. So it really allows mixing, which after birth is not necessarily happening. And then postnatal circulation, after birth, critical congenital heart disease, this is where the babies run into problems. They can quickly decompensate due to the closure of usually either ductus arteriosus and the foramen ovale. So for left ventricular outflow lesions, these are really dependent on the ductus arteriosus to provide systemic output. So in coarctation of the aorta, the lower body is dependent on the ductus arteriosus. In pulmonary atresia, in transposition, the blood flow is dependent on the PDA and the second level of shunting, so either an atrial septal defect or a ventricular septal defect to provide adequate mixing so that you don't have two series of blood flows in parallel rather than in series, which is what normal circulation is like. In pulmonary atresia, the blood flow to the lungs to oxygenate the blood is dependent on the ductus arteriosus to kind of flow from the aorta to the lungs to oxygenate the blood. And then total anomalous pulmonary venous return, depending on the type of lesion it is really dependent on some level of either interatrial shunting or ventricular septal shunting for systemic output through the left ventricle. So knowing that, and knowing that these things can, as we'll talk about a little later, can be hard to pick up postnatally, we try to find babies before they're born and fetally screen for these critical congenital heart disease. And so there's really two components when it comes to the obstetrician. It's identifying the patients that are high risk for having congenital heart disease, and finding, and then anatomic screening. So the American Heart Association published a scientific statement in 2014 that has probably almost all of the important fetal cardiologists out there on the diagnosis and treatment of fetal cardiac disease. And they put forward a really extensive chart looking at the indications to screen for screen by fetal echocardiogram. And they include maternal indications, family history of cardiac disease, fetal factors, as well as pregnancy-related factors. So maternal indications for fetal, to directly send a mom for a fetal echocardiogram. So first, gestational diabetes, or pre-gestational diabetes, so if they have type 1 prior to pregnancy. These are generally thought of as having for the gestational diabetics, as having a hemoglobin A1C greater than 6%. And these moms have a higher relative risk of heterotaxy, truncus arteriosus, transposition, and as well as single ventricles. PKU, or phenylketonuria, that risk for these moms is really if it's poorly controlled, if they're not following diet very well, they're at higher risk of congenital heart disease. Lupus or Sjogren's, anyone with a positive anti-SSA or SSB antibody, the Rho and La antibodies, these moms are at risk for the development of heart block, and that's specifically between the 16 to 28 weeks of gestation. They also are at risk for developing a cardiomyopathy due to the autoantibodies against the conduction system in myocardium. And then teratogen exposure. So if you have non-specific anticonvulsants, lithium, ACE inhibitors, retinoic acid, vitamin A, paroxetine specifically, and NSAIDs, they have a higher risk of developing congenital heart disease. And depending on the medication that they're on, is anywhere between 3% risk to 25% risk. The recommendations also look at family history reasons to send moms directly for fetal echocardiogram, regardless of the anatomic screening. Oh, sorry, maternal torch infections can also be there. But family history reasons would be really first-degree family members with structural heart disease. So this includes maternal disease, where the risk depends on the specific thing, but it's anywhere between 3 and 20% risk of the fetus having congenital heart disease. Paternal disease or sibling disease, all of those are included as reasons to screen the mom. For second and third degree family members, we actually, that have structural heart disease, we really have questionable value for that. So if a grandfather had totality flow, or somebody else had a hole in their heart that's a little bit more distant, cousin or aunt or uncle without disease in the parent or sibling, the need to directly screen that patient, send them directly for fetal echocardiogram is not necessarily indicated unless there's other concerns on the anatomic screening. And then when we look at the other family history, so things like hypertrophic cardiomyopathy, Marfan syndrome, connective tissue disease, where they have a risk later in life of developing disease, whether it's a dilated aorta or some sort of cardiomyopathy, there's really no value in screening by fetal before birth unless there's other concerns that have developed, just because most of the time this doesn't develop until later in childhood. So there's nothing that we can tell usually before birth whether they're going to be at a higher risk or not. Then there's fetal-specific indications for fetal echocardiogram outside of having an abnormal cardiac screening, and those include rhythm abnormalities. So the risk is really dependent on the arrhythmia that was seen or present in the obstetrics exam. So tachycardia, bradycardia, or irregular rhythm, so PACs or things like that, when they're really present for more than a week or two for screening. for the irregular rhythm. But if you see persistent tachycardia or bradycardia, that should be your reason just to automatically screen, as the risk for congenital heart disease for bradycardia is about 20%. For tachycardia is more like 40%. And then non-cardiac anomalies. And by system, the risk is variable, but really overall, if you see other extracardiac anomalies, including neurologic, respiratory, GI, GU, or musculoskeletal anomalies, you have somewhere between a 20 and 45% risk, absolute risk for the fetus to have some sort of congenital heart disease. And finally, if there's a chromosomal abnormality detected, so if you have trisomy 21, trisomy 18, trisomy 13, they all are at high risk of developing some sort of congenital heart disease, so they should be automatically screened if that comes back positive on the prenatal testing, whether you do cell-free DNA or any other of those prenatal testing. And then finally, there's pregnancy-related indications. So there is some data, there's lots of data on monochorionic twinning, so monochorionic diamniotic twinning can be at very high risk for twin-twin transfusion syndrome, so TTTS. But even without that, these twins are slightly higher risk than the general population of having congenital heart disease. And then monochorionic diamniotic twins are at the highest risk of twin-twin transfusion syndrome, where there's a donor and a recipient twin. The donor twin may develop right ventricular outflow tract obstruction to the point where they can actually develop an acquired pulmonary atresia intact septum type of heart disease. And they have a risk of cardiac anomalies even in the recipient twin of having high output almost heart failure because of the high amount of blood that they're receiving. So they have about a 10 to 11% risk. When identified early, this is usually identified maybe somewhere between 14 to 16 weeks gestation. Fetal intervention can occur, and there's actually something called a CHOP score where we can assess their risk and the severity of their twin-twin transfusion based on fetal echocardiography. And we can actually look at both babies' hearts within a fetal echocardiogram. There's also some data out there for in vitro fertilization pregnancies that they have maybe a 1.5 to 3% absolute risk of congenital heart disease, which is slightly higher than the general population of about 1% risk, like we had mentioned before. So beyond those automatic referrals for fetal echocardiography to look for congenital heart disease, there's also the obstetric anatomic screening. This is the first line for patients that are low risk that don't otherwise have an indication for fetal echocardiography, and is obviously done, you guys know a little bit more than I do, around the 18 to 20 weeks gestation. The standard cardiac views is a 4-chamber view, which you can kind of see. You're not used to echo or ultrasound at all. Those are your two atria here. This is the ventricle, and that's your other ventricle. This is kind of the standard 4-chamber view of the heart. And that can be obtained in usually about 95 to 98% of anatomic evaluations during pregnancy. If you can't see it because of the baby's kind of orientation within the mom, then you can bring it back in a few days or a week or so, and many times they are in a more amenable position. And can really theoretically detect about 50% of all serious cardiac malformations just with this view alone. The tricky part is that there's a low detection rate with just this view of congenital heart disease in these low-risk populations, about 10 to 25%, when using just that single 4-chamber view. And so pediatric cardiologists really advocate for maybe 2 views at least, or maybe 3 views of the heart to really determine a normal screen. So the views, so the sensitivity of obstetric anatomic screening actually increases to almost 90% if we can get a couple extra additional views. So these key views are the 4-chamber view. That's the one that we looked at before, where you have your 2 atria here. This is your right ventricle here and your left ventricle. If you add in the outflow view, then you can look at both the aortic outflow and the pulmonary outflow to look at size and make sure that they're present. So here, we're looking at, that's kind of a short kind of cut of the right ventricular outflow tract. That's your pulmonary artery with your branches there, right next to the aorta. And then here is looking at more of a modified, called the 4-chamber view, where we get to see both the inflow, so the left atrium to the left ventricle, and the outflow of the aorta here. And then the 3-vessel view with the trachea, we get referrals all the time when that view is abnormal because we can see sometimes right aortic arches and vascular rings this way, where you get into the pulmonary artery and the aorta here and see that how they join together with the ductus arteriosus. And then actually that's your superior vena cava. So the cardiac diseases and the views that are required for diagnosis. So I kind of split it up into the 4-chamber view alone and then those that are requiring additional views. So 4-chamber view alone, you should be able to see an atrioventricular septal defect because there's a common AV valve, that kind of crux of the heart doesn't form. Double inlet left ventricle, which is a variant of a single ventricle Epstein's anomaly because that tricuspid valve looks really abnormal. Hypoplastic left heart syndrome because you have maldevelopment of the left ventricle. Pulmonary atresia with intact septum, you may or may not be able to see depending on the development of the right ventricle. And then complex single ventricles. Obviously, if you don't see 4 chambers, then that's going to be something you can tell. From the outflow, or with the addition of the outflow and additional views, you're also able to see things like critical aortic stenosis, things like double outlet right ventricle, so you can see both the pulmonary artery and the aorta coming off the right ventricle. Pulmonary atresia, as you'll see, really nothing, usually they're kind of nub or a really big plate-like thing in between that right ventricular outflow and the pulmonary artery. Tetralogy of Fallot, transposition of the great arteries, coarctation of the aorta, interrupted aortic arch, and total anomalous pulmonary venous return. Going back to what we had talked about from a critical congenital heart disease then, I bolded all the ones that we consider critical. So you can see that there's some very significant heart disease that you should be able to pick up, and really sometimes even as complex single ventricles can be considered critical. But it's only about half of what we would also want to be able to screen for. And so this is why pediatric cardiologists feel like it's really important to try and get a couple extra additional views when we get obstetric anatomic screening. So, based on the obstetric screening, when do you refer to us in fetal cardiology? So there's any maternal, fetal, or pregnancy-related indication for those guidelines that we talked about. If you have an abnormal obstetric anatomic screening, so an abnormal 4-chamber view, I have a few examples. So left ventricular or right ventricular size discrepancy, which is one of these indications that could suggest the development of a hypoplastic left or right heart syndrome, or could be an indication of possible coarctation. So here you can see that this is our right ventricle, and you can see how small the left ventricle is comparatively. They should be equal size prior to birth. Evidence of a ventricular septal defect, so if you see that in your 4-chamber view, you can see that here's your ventricular septum, there's a big hole there right in the middle. A small left atrium, or something that sits right behind the left atrium, can be an indication of total anomalous pulmonary venous return, where it seems like maybe the atrium is septated. So here, it's a little bit different view. Babies are always turning all over the place, so you have to learn to kind of flip your brain a lot. So here's the right atrium and right ventricle. You can see it's actually a little bit larger than the left side. Here's the left ventricle, here's the left atrium. You can see there's kind of this line here, and these are actually the pulmonary veins coming in, where there's a line there. So a lot of times where TAPVR, they come right all the way back really close to the left atrium. They don't actually go there, then they drain up or drain down. And then you get abnormal outflow views. So you can't see one of the outflows. This is a patient with truncus arteriosus. You see one giant outflow, but there was no other outflow seen in the study. You see a size discrepancy between the outflows. So this is a patient with hypoplastic left heart syndrome. You can see that this is the pulmonary artery here in that 3-vessel view. That's almost double the size of the aorta, which is here. There's reverse flow in the outflow, so sometimes during the anatomic screenings they'll do color Doppler, which shows us the direction of the blood flow. So in this patient, it's another patient, this is a patient with pulmonary atresia, so this is the aorta here as it comes into the duct. And you get this, you're just gonna have to trust me on this. This blue flow means it's going this way, and then this is the pulmonary artery, so it should also be blue, so they should be running in the same direction. We're seeing red flow, which means blood's moving in the opposite direction, meaning that the ductus is actually supplying the lungs because there's no antegrade flow. And then if there's abnormal fetal heart rates, so if there's significant bradycardia or tachycardia, or if there's persistent atrial kind of irregularities, those are reasons to have a fetal cardiologist check things out. So fetal echocardiography, what do we do as fetal echo docs? We usually do our first screening between 18 and 22 weeks of gestation, but we've definitely done later. And there are some people, mostly in a research setting, that are doing first trimester screenings. But we always try to do it after the obstetric anatomic ultrasound, even if we know that there's a maternal or a pregnancy indication for it, so that we kind of know going in if there's any suspicion, but also know if there's any other extracardiac anomalies coming in. Our complete study is a full anatomic assessment. It's pretty impressive what we can see. So we do cine clips, so little movie clips, so we can actually see how the heart's moving and functioning. We do color Doppler assessments, so we can see the direction of the blood flow, but we can assess for valve leakages or stenosis, and we can measure that color Doppler to see how narrow a valve is. We can also assess fetal heart rhythm, and we're lucky in Wisconsin that Dr. Strasburger is around, and she does more extensive fetal magnetocardiography, which can actually kind of build a ECG based on fetal rhythms if we have really significant questions. And so, in addition to those views, I had shown you earlier, we do a lot of other views to look at the heart and really do a full assessment. The one part about fetal echocardiography is it's a little bit limited in that physiologically there are some things that are tricky to see. And so small ventricular septal defects, small valve abnormalities where there's not a lot of hemodynamic effects early on in pregnancy can be missed. We also can't see the actual valve leaflets, because if you think the fetus's heart at 22 weeks, if you think how big the fetus is, their heart is about the size of their fist. So it's pretty small, so we can't tell if it's bicuspid valve versus a trileaflet valve. We can just see how it works with color Doppler. The other things that we can miss are small VSDs, partial anomalous pulmonary venous return can be really hard to see. And so I always tell parents that if we've done a fetal echo, that if the pediatrician is ever worried, it doesn't give you a clean bill of health, it just tells you that we're not gonna see anything really serious after delivery. The last thing that we can miss is coarctation of the aorta, and that's due to the large ductus arteriosus. So unless the aorta and transverse aorta is really, really hypoplastic before babies are born, we sometimes can't quite give a straight answer or worry. So, moving on. So what does that mean? So prenatal detection of congenital heart disease the rates have really improved over the last 10 years, and Garrick Hill was one of our former fellows and docs who did a study in Wisconsin itself at looking at our prenatal detection rates. And so he looked a study that was published in 2014 that our overall detection rate in Wisconsin was 44% prenatally in 2007. And with education and really more aggressive fetal echocardiography, we've improved that to almost 70% in 2013. His study also looked at frequently missed fetal cardiac diagnoses, and these are notorious no matter where you are, not just Wisconsin. So those are total anomalous pulmonary venous return, which is this bar here. This is postnatal is the white bar, and prenatal diagnosis is the black bar. So you can see TAPVR is probably one of the hardest things to check to pick up. Pulmonary stenosis, coarctation of the aorta, aortic stenosis, and transposition are the most commonly missed diagnoses. And if you look at those, all of those could really be considered critical congenital heart disease. And so these, and a lot of these are really dependent on other views outside of just the 4-chamber view. And that's, we're really pushing for things like the outflow view. We've really improved our diagnostic rate. We also realize that misdiagnoses are more common in rural areas, high poverty areas, or if the baby has no other extracardiac abnormalities or chromosomal abnormalities. And so really having a high level of suspicion on any baby that is getting an anatomic screening, and referring those moms that are at higher risk for their fetus having congenital heart disease is really key in trying to lessen the the amount of misdiagnoses. So what it means, I mentioned earlier that prenatal diagnosis in Texas has shown that because you can plan deliveries a little bit better, it has improved morbidity and mortality. And that's that Texas Birth Registry study. They found that patients, specifically with hypoplastic left heart, had lower mortality if they delivered less than 10 minutes away from the tertiary center or in the tertiary center. And the tertiary center is considered a place where they can perform complex fetal or neonatal congenital heart surgery. Another study looked at neonates with critical congenital heart disease requiring emergent neonatal cardiac intervention, so that's including an atrial or prostaglandins, or even surgery within the first 24 hours of life. And those babies did better preoperatively. They were healthier going into surgery and had shorter hospital stays when they were diagnosed before birth. And then this is a study out of China that found, or a meta-analysis that was published out of China that looked at transposition and left ventricular outflow tract obstruction. And these babies have decreased mortality when they're diagnosed prenatally because they don't present looking quite so ill and cyanotic. So how does that prenatal detection translate to postnatal care? Mary D'Onofrio, who is a fetal cardiologist in DC, created this risk stratification tool for her own hospital in DC on how to take care of patients after delivery and where they should deliver. Their hospital didn't have any deliveries unless you delivered in the operating room of the children's hospital. So they had to figure out where moms could deliver depending on their heart lesion, and they would risk stratify them in kind of this 1 through 4 category range. And so she would designate their risk status as a fetal cardiologist, and that would really translate then to the neonatologists and the surgeons on where these babies were going to deliver. We took that in Milwaukee, and this is something I actually developed in my fellowship, is we created a fetal level of concern. So it's our own risk stratification tool that's specific to our Wisconsin patients, that when we have a mom that has a fetus diagnosed with congenital heart disease prior to birth, we give them a risk stratification determining where the baby can deliver, and in addition to that, we actually helps dictate whether the baby will automatically need umbilical lines, prostaglandins, how soon does cardiology need to assess the baby, and who is notified of the delivery. So for us, it includes, does the OR need to be on standby and things like that. So the severity increases with your number, but we have a 1 through 5 scale that we actually put in every single fetal note, so that when mom comes in, whether she comes into Milwaukee to deliver or here or anywhere else, and there's a known diagnosis of congenital heart disease, we kind of know what we need to do going in. So after delivery, many of you see babies in the newborn nursery or are actually attending deliveries. And this is, I remember as when I was a hospitalist for a year, the neonates with critical congenital heart disease, that was like my worst nightmare. And they can have really 3 different looks, and you never know what you're going to get. You always have to think of congenital heart disease, but throughout the newborn period, because you just never know how they're going to present. So first, they can be immediately symptomatic, and it's very clinically apparent. They can be later symptomatic, which is eventually apparent, or they can be completely asymptomatic and clinically silent until they come into an ER looking really horrible. And so the key of this is never trust a neonate. I think that was the one piece of advice in pediatrics training that was hammered into me, was never, ever, ever trust a baby. So if you're concerned or have a question of a diagnosis, you trust your gut and test for congenital heart disease. Nobody is ever going to no cardiologist will ever blame you for just starting prostaglandins because you were worried, because kids really, they don't tell you the whole story. So up to 30% of neonates may not have clinically evident disease. So the key is trying to figure out how to identify these kids early and then what to do. So the immediately symptomatic neonate, these are the kids that present with severe cyanosis. They look blue completely coming out of the womb. And these are the diagnoses that we first think of as total anomalous pulmonary venous venous return with obstruction specifically, or transposition of the great arteries. The babies present immediately in shock. These sometimes go hand in hand with the cyanosis, but they have low APGARs, poor perfusion, low saturations. Sometimes these can be our hypoplastic left heart syndrome. Not all babies with HLHS present like this, but the ones with an intact atrial septum, so they have actually no systemic output, can present like this. Some of our transposition of the great arteries with, again, an intact or restrictive atrial septum. Severe Epstein's anomaly, because they have significant tricuspid regurgitation and little pulmonary, antegrade pulmonary blood flow, and then obviously our obstructed total anomalous pulmonary venous return babies. The later symptomatic neonates are sometimes the tricky ones, but frequently ones that you can pick up within the first day or two after delivery. These are the kids that have developed cyanosis. This is the kid I now always think of, Jimmy Kimmel is what I think of now. So these are the kids with tetralogy Fallot or pulmonary atresia, critical pulmonary stenosis, some transposition of the great arteries when they do have a ventricular septal defect. And I'm just going to put total anomalous pulmonary venous return everywhere because it can present doing anything. The later symptomatic neonate within the first 24 to 48 hours who develop shock type of symptoms, so poor feeding, poor perfusion, sick looking. These are things like critical coarctation of the aorta, critical aortic stenosis, hypoplastic left heart syndrome, and then interrupted arch. So they all have a theme there. They're all some sort of outflow obstruction lesions. And then finally, respiratory distress or tachypnea. These are truncus arteriosus and total anomalous pulmonary venous return again, but also things like ventricular septal defects, which aren't necessarily considered critical defects, but can also present with just comfortable, these kind of babies that just breathe like a gerbil. You kind of get it, they kind of just breathe really fast, but look completely happy at the same time. So next is the asymptomatic neonate. These are what we all are terrified of, myself included, and these are the ticking time bomb babies. These are the babies that you really have to rely on your clinical suspicion, your physical exam, and your kind of gut instinct to diagnose. These are the patients that are initially might be asymptomatic in the nursery, but present at 2 weeks of age or a week of age, looking very, very sick. And these are really, the big ones are left ventricular outflow lesions, so hypoplastic left heart or those variants, coarctation, critical AS. Also going back to interrupted arch, just depending on how quickly that PDA decides to close. Transposition with VST and pulmonary stenosis, sometimes tetralogy Fallot too, depending on how significant the pulmonary obstruction is. So to screen these in the newborn nursery, if you're going up and you're seeing a baby, there's two key kind of initial screenings and then a follow-up. So it's a physical examination, which I know some people think is going out of style, but I think is really key. Pulse oximetry screening, and then the hyperoxia test. So the cardiac focus physical exam. Pulses, pulses, pulses. This is considered the sixth vital sign in cardiology fellowship. It is, you know that what their blood pressure, their heart rate, their status, and then you make sure that you know what their femoral pulses feel like. You check their vital signs, like I said, blood pressures, especially uppers and lowers. Those can be misleading, but it is good to at least check that heart rate. Obviously, if they're having an arrhythmia, you want to know if their heart rate is 300, and then pulse oximetry in general. We go back to pulses, pulses, pulses again, because if you haven't checked them already, you need to check them again. You want to assess for other extracardiac abnormalities and signs of chromosomal disorders, feel their liver size, and for good measure, just feel their pulses again. The cardiac exam specifically, you want to start with just putting your hand on their chest. If they have severe stenosis, you might be able to feel a thrill. You can note the location of their kind of PMI, whether it's on the left side or the right side, which every once in a while, there'll just be that kid that you're like, oh yeah, all their heart sounds on their right, and you realize either they have a giant pneumothorax or they're dextrocardiac. Then you want to obviously listen. You listen for abnormal heart sounds. So if you hear a single S2, which I know is really hard to hear splitting an S2 if anybody has a heart rate over 100 or 120. So that's honestly difficult, but if you notice a really single, a prominent S2, that would be an abnormal heart sound. An S3 or a gallop obviously would maybe be an indication of poor function. If you hear a click for bicuspid aortic valve and aortic stenosis. And then murmurs. There are a few normal murmurs in neonates, but if it's persistent and it doesn't really vary, if it's harsh, or if it's not really in the ductal location, kind of on that left upper by the clavicle, then there's nobody that will, if you want a cardiologist to listen, that's always a valid thing, or get an echocardiogram. Murmurs might occur after, you might not hear them initially, but occur after 24 hours a day, just specifically in pulmonary outflow tract obstruction, and that's just because murmurs are related to pressure differences, and the pulmonary vascular resistance takes a day or two, or 2 weeks or 6 months sometimes to drop, and so you might not hear a murmur until there's actually a good amount of pressure difference there. So pulse oximetry screening. So in addition to your really focused physical exam, pulse oximetry screening is really recommended by the AHA, the American Academy of Pediatrics, the Department of Health and Human Services. Every sort of organization really advocates for neonatal pulse oximetry screening. In Wisconsin, it's state law that children undergo a mandatory pulse ox screening after 24 hours of age. And if you look at the false positive rate for that, it's only about 0.06%. Has a sensitivity above 90% or a sensitivity of about 75%, but the specificity though is well over 90%. And they actually looked at this in a study of about 3,600 infants with CCHD between 1998 and 2007. They found about 25% of disease wasn't really diagnosed in the newborn nursery, was not diagnosed in the newborn nursery, and those missed were more likely to be have preventable death and things like that, when many of them could have been found on pulse oximetry screening. So the screening process, the keys for this is after 24 hours of age, or as late as possible prior to discharge. I know that sometimes moms want to deliver the baby and then leave 3 hours later, but really trying to advocate for them to stay 24 hours just to observe the baby for multiple things, but also to be able to do your CCHD screening to give time for maybe the PDA to close or get smaller. And then you have to make 2 measurements. So it has to be in the right hand. The first brachiocephalic vessel in babies, unless they have really wonky aortic arch anatomy, but in general, that first brachiocephalic also goes to that right hand. So that's always going to be kind of a preductal saturation. While the left hand is not as reliable for that, because it, especially for coarctation, your left hand could be pre-coarc or post-coarc, so just doing the right as a rule of thumb is always the kind of right way to go, and then either lower extremity, again, because that left hand is really unreliable on where it lies within the aortic arch anatomy. Sorry it came out very small, but the pulse oximetry screening protocol is something that most newborn nurseries have posted everywhere to know, but it should, basically, you do your screen and then you look at your results. So if you have less than 90% in any sort of right hand or foot, it's kind of a do not pass go, do not collect $200, you just kind of go for a positive screen and then get a cardiology consult or an echocardiogram. If you're between 90 and 94% in the hand and foot, or more than 3% difference, so if your hand is 99, your foot is 95, that would be considered kind of a indeterminate screen. So you repeat that in an hour, the same types of thing, same 3 things occur, you repeat it in an hour again, and if you get that 90 to 94% or greater than 3% difference, that's considered a positive screen. You just get to check 3 times for that. Then finally is if it's greater than 95% in the hand or foot, and it's less than 3% difference between the right hand and foot, that's considered a negative screen, and you can kind of exit that screening protocol. So the benefits of the universal pulse oximetry screening, it's pretty easy. And when you look at the data for it, there's a study out of Sweden that was a prospective study from 2004 to 2007. It looked at the universal pulse oximetry screening in that country. And it found, this was published in the British Medical Journal, found that it was better than physical examination alone. And the misdiagnosis rate went from 28% to 8% with just the addition of with the addition of pulse oximetry screening to the physical examination. And there were no babies that had died when they had the addition of the pulse oximetry screening done. And I think about 5 babies had died from missed cardiac diagnoses with physical examination.
Wow.
And then New Jersey did a statewide screening program in 2011 to 2012. They reported that pulse oximetry screening was really successfully screened about 99% of their 73,000 eligible infants. So, but you look, it's still a pretty rare thing just on the pulse oximetry screening to get positive. So out of those 73,000, 49 infants failed the screening, with 19 having other clinical signs of disease. So there were 30 infants that had diagnostic evaluations due to the screening alone, and 3 of those 30 had previously undiagnosed critical congenital heart disease. And then 17 out of the 30 had other important underlying medical conditions, so that's primary pulmonary, persistent pulmonary hypertension, or neonatal pneumonia, or other things that were noted. So, out of China, they did a large multi-center prospective study of hundreds of thousands, over 100,000 newborn infants between 2011 and 2012. And if you guys know pediatric studies, you never get that many babies in anything. So the sensitivity in detecting the critical congenital heart disease was really greatest when you use the combo of pulse oximetry and clinical examination. So as much as we like to trust technology, we're really still pretty good when we use tech and our kind of clinical acumen together. So pulse oximetry screening alone was an 84% detection rate, with physical examination alone is 77%, but with together you got a detection rate of about 93% of critical congenital heart disease. I think it's very good. So the kids screen positive, what next? So the follow-up testing options really include hyperoxia test, chest x-ray, echocardiogram, or phoning a friend, consider transfer depending on the clinical status of the baby. But you want to stabilize the child. So if you need to place lines, you place lines. Initiate prostaglandins depending on how the baby looks. And prostaglandins are a pretty low risk. There is that risk of apnea, but they're pretty low risk medications. So use them if you have the ability to and you're worried. You can intubate the child if you find that you're worried about critical congenital heart disease, so you can decrease their metabolic demand. You can give them a blood transfusion and transposition. That's what we do. If their stats are really low, we try to increase the box cards, as I was taught how to think about it. Or you can give them sedation or anything else to decrease their metabolic demand. You can also perform that hyperoxia test. So the rationale for that is just in congenital heart disease, right to left shunting causes cyanosis. That's decreasing your inspired oxygen. Shouldn't really change that shunting. While in respiratory disease, it's related to pulmonary venous desaturation, so supplemental oxygen can increase pulmonary venous oxygen levels and decrease your deoxygenated blood. And so you measure the oxygen pre-ductal at baseline, you measure their oxygen post-ductal or pre-ductal after breathing 100% oxygen for 10 minutes. You can do that in an oxy hood, or if they look really bad, obviously you can use an ET tube. And sometimes if you're resuscitating a baby, you're essentially doing a hyperoxia test anyway if you're trying to get their sats up. But the interpretation, if you're technically doing a real hyperoxia test on maybe an asymptomatic baby, is technically you require a blood gas pre and post, but you can kind of use pulse ox as a kind of a four man's way to do it. But you really need to look for a significant increase in your PaO2. Really, you're hoping to get more than 150 millimeters of mercury during the hyperoxia test, because that'll indicate more likely a pulmonary. But you're not done yet. Baby goes home and you're like, I feel really pretty good about everything, but unfortunately there's still types of critical congenital heart disease that get missed in the newborn nursery because they're still really asymptomatic. And so these most commonly missed diagnoses, like we had talked about before, are the left ventricular outflow lesions, and then things like pulmonary stenosis and these pink tets that have more progressive stenosis after delivery. So diagnosing them in the office after you're seeing them on the newborn visit really is the same things we had talked about before. So progressive cyanosis, irritability, lethargy reported by the parents, poor weight gain, poor feeding, sweating with feet, tachypnea, all the things that would make you worried about a baby anyway are the things to kind of raise your suspicion. You do a focused physical exam where you do pulses, pulses, pulses. Upper and lower extremity blood pressures can be a little bit more helpful at this stage of the game. You do your cardiac examination, you look for their liver size, and then measure their pulses again, because it's one thing. If you don't forget anything else, that's the pulses are really the key for our left ventricular outflow lesions. So I keep talking about them because coarctation is actually a relatively common disease in the spectrum of congenital heart disease. It's probably about 15% of the things that we see. And neonatal blood pressure can be hard to obtain unless you're really experienced at getting Doppler blood pressures. So there's a study that looked at 90 infants with critical coarctation, with 21% being born at centers with pulse oximetry screening, and found that half of these neonates were discharged undiagnosed, even with pulse oximetry screening, and half of these infants were then readmitted with circulatory failure, including in death. And so the murmur and or weak pulses really had been detected in maybe a third of these discharged infants, which could really improve that, those patients that would present really with more shock type physiology. So from the office, when you want to refer, if you do see cyanosis again, you see respiratory distress without an obvious respiratory cause, with or without a murmur, poor feeding or weight gain, physical exam findings suggestive cardiac disease, abnormal pulse ox screening in the office, any genetic disorder that has cardiovascular disease associations, or an abnormal EKG or chest X-ray in your screening protocol. So, lots of data, but in summary, congenital heart disease is a common pediatric and congenital malformation in children. It's frequently not diagnosed prior to birth. There are many documented indications for fetal echocardiography. So when you have them, please send them to us. And then postnatal diagnosis of congenital heart disease really should include a combination of using your technology with pulse oximetry screening, with physical examination, and pulses for postnatal diagnosis. So I want to say thank you guys so much for letting me come and talk to you. I apologize, I was a little bit tardy. I have no great sense of direction. I'm happy to take any questions, either in the audience or afterwards. I'll be able to